Welcome, my name is Berni Machío. I'm a physiotherapist, osteopath, and non-invasive neuromodulation expert. In this clinical case video, I'd like to explain a case of internal knee pain with chondropathy. This is an 82-year-old elderly patient with pain on the inner side that was reflected a little bit towards the inner tibia. It's a fairly classic pain that we see. At the radiological level, we have an X-ray and MRI referred by a doctor. After a musculoskeletal examination, strength test, nerve check, and nervous system and tissue assessment, two things caught my attention. First, the limitation he had at the coxofemoral, and second, something that was detected through palpation, a densification inside the knee. Several nerves are drawn here, but two main ones. The first is the tract, the main nerve, an important terminal branch of the lumbar reflection, which is the femoral nerve coming from L2, L3, L4 at the metameric level. Here we draw the branches of the saphenous nerve, the sensory nerve, on the inward side. There's a sensitive part on the inward side, and we're going to put the directional electrodes where we need to put them. To begin with, we know that he was a patient who had quite a significant limitation in the coxofemoral. Before working distally, we'll work with program 2 at the metameric level. At the spine, if you want to be a bit more specific, we'll put the directional electrode at the transverse metamerically. So what will we use it for? To work all the muscular tissue first. In this way, we can work different psoas tracts. Work as much as you can. We really need to release this inguinal area and the entire trajectory, muscular and fascial branches that pass through and cross this femoral nerve. We can make different rakings for different openings directly in the area. Work, if you can, with the elasticity of the whole band of that quadriceps to take away any negative inputs that we might have. We can always use the pointer as a tool to locate the spots we need. It's easy to locate the exact point where we want to work with this directional electrode by first locating a femoral nerve. When we have worked all this hip and this internal part, we'll locate and place that directional electrode, and then we'll start to treat with a program. In this case, I recommend using program 7 instead of program 6. When we started with program 2, we'll go to 7 or 6, depending on the patient, also the nerve feeling they have. In this case, I began with program 7 to improve conductivity and all the nerve tracing that in the end will innovate it, and take advantage of what is a fairly densified area. As a recommendation, we'll start to release, we'll start to mobilize in different directions. We'll do tracing, scraping, we'll release the muscular tract of the posterior musculature, hamstring musculature. We'll release that internal bulk and tension, that basto-adductor fascia, releasing the whole area, different directions, flexing to work the tissue. It's essential to work the tissue with different tensions to release, as I can see here, those little branches at the saphenous nerve endings. Now, don't be afraid to use rolling techniques while working, releasing in different areas, and the same following towards the more distal part. When we finish working that section, what should we do? We'll use the pointer. We're going to locate nerve fibers of this saphenous nerve, to be specific, when placing the directional electrode. Now we have two options. Put program 6 directly, work on the pain, analgesia directly on that point, or even combine it with 5 and 7 to improve both at tissue level and also for improving mechanotransduction, improve the local nervous tissue to be able to continue working on lower strokes and directly at the last part of the session to be able to work on lower or higher joints and improve the points and pulleys of the balance in that area. As always, an important part of this is also the readaptation we do afterwards, the muscular work and the work that the patient can do at home to improve everything. Let's turn to the evolution of our patient with chondropathy. After following, you remember program 2 at the metameric level, program 7 at the femoral level, and then a program which is focal on the point of the saphenous nerve, which is the spot of the chondropathy that was hurting him. This patient, with 3 or 4 sessions and a relatively similar protocol, has already shown progress, always combined with our required readaptation work. Also, a very interesting thing in this patient that I wanted to share with you is the later work, the progress, the passive work. This patient only comes for passive work every 6 or 7 weeks to focally to work on the improvement, analgesia, and mechanical transduction of that specific tissue. I'll end here and see you in the next videos.